Hi, students, and welcome to our series in emerging infectious diseases, emergency preparedness, and strategies. Today, we're going to talk about are related to crisis standards of care in healthcare. This is a fairly brief overview. I just wanted to give you a sense for what that means in today's world and in today's planning for emergency preparedness. It definitely goes hand in hand with understanding the planning that goes behind facility surge or community surge, and those are pieces that you will get in your courses if this is part of a course, or in your online series if that's the case. So my objectives for today are to make sure that you understand the difference between the different levels leading to crisis standards of care. So conventional, contingency, and then crisis. And then we're going to talk about both trigger points to get to contingent and trigger points to get to that crisis level, and what that means and what that might look like. Just for a little bit of background, I just want to make sure you understand the difference between capacity and capability. So a surge capacity is your ability to, as a facility, as a healthcare facility, to care for a market increase in volume. Now, whether that's a sudden event related to a trauma-based disaster like tornado or hurricane, or a slow-moving event like an infectious disease that has slightly different nuances when it comes to capacity or the speed with which you reach that. And that's just sheer volume versus capability, which means, do you as a facility have the capability to handle specialty cases? So if this is a large burn and blast event, do you have enough capability to handle an excess of burn patients? If it's a pediatric event, do you have the capability to address pediatrics? So those specialty areas. So those are different, whether it's, again, able to just surge in general or surge with specific types of specialty disciplines, and that's important. So some of you may or may not have learned the facility surge techniques based on what we call the S's and the T's. And it's pretty self-explanatory. What we do is we go over, as a facility, if you need to surge, what are the implications for space, staff, and stuff, which means supplies, and then triage, treatment, and transport. So it doesn't matter if you haven't had that yet in your training, but what I wanted to say is that we're really going to be focusing today on these three phases that lead up to crisis standards of care as it pertains to space, staff, and stuff. So when I talk about the three S's, that's what I'm talking about, are those three elements right there. So these are the three levels of inpatient surge and different levels of care, right? So conventional care, contingency care, and crisis care. So let's start with conventional care. So these are when, and here are the three S's, staff, stuff, and space are used, but they're used consistent with daily practices, right? So this may actually be in an event that triggered the activation of your disaster plan, but you're still delivering care that's consistent with daily practices, right? Nobody's care is compromised in any way by what you're doing in terms of operation, even though you might be surging up to handle many more than you would normally handle, but the care itself has not changed. So that's still your conventional care. You might be doing some mild alterations in your documentation. You might be delegating non-clinical duties like meal delivery to other non-clinical staff. So maybe you're pulling your admin staff out of medical offices and asking them to deliver meals. From a patient standpoint, that's not a change in my care as a patient. So it's really, in effect, transparent to the patients receiving care in that facility. From a supply standpoint, you might be making some, conservation strategies. You might not be doling out as many things that you normally would, and maybe you're watching the numbers. But again, from a patient standpoint, there's really no difference in the care. Same thing with medication classes, whether you're using brand names or generic or different classes for different diagnoses and treatment. It's not obvious or does not affect the care that you're providing to your patients at that point. So what I've got here is a timeline just to give you a sense for how your space is influenced by this regular conventional care, within regular conventional care, given that you have a surge in patients, for example. This timeline here is, because it's based in hours, it's really more reflective of a sudden increase in surge. So let's say you have a tornado in your area, or you have, or any other disaster that causes multiple casualties to show up at your hospital. This is kind of what your timeline might look like. For a slow-moving infectious disease, this timeline might be days or weeks. It just depends on what the speed with which you're receiving these excess patients, right? So remember, we're still in conventional care. So in the early hours of a trauma-based, or in the early days of an infectious disease base, you might be filling all of your available staffed beds, right? These are still regular beds that you've got on your wards, etc. And what you might be doing is you might be discharging patients a little earlier than you might normally, just so you can free up some of those beds. As you get further into this, you might actually be calling more staff to handle this increase in your inpatient status. And you might be taking beds out of storage that you've already got and putting them in those empty slots that would hold a bed in a regular patient room, right? So this isn't anything, you're not putting these beds anywhere that you wouldn't normally put them if you needed extra space. As time progresses again, and I'm looking down here in the 4 to 12 hours, once you've used up all of these beds that you had in storage, maybe you're leasing or you're borrowing more, but you're still placing them in a regular bed slot with medical gases, etc. So from a patient standpoint, and again, these are, staffed or licensed beds, from a patient care standpoint, there is really no change in the care that your patients are getting. Now, when you get down to this 12 or 24 hours, which obviously might be later in infectious disease, now you're beginning to see some impact on your operations, to where you're really feeling the pressure on your patient care, and maybe your patients are starting to sense that something is really changing in your environment, and it might be time to switch to contingent care. And that makes sense, right? So contingent care are when your, again, space, staff, and stuff are used not consistent with your daily practices. So this is a little bit different way of operating now in your facility. You've had to sort of ramp up, you've had to sort of make some changes that would be very different from your care that you gave a day ago or 2 days ago or a week ago, right? So, but know that this care that you're giving under this contingency care is still functionally equivalent to your regular daily operations patient care, right? There's not a marked difference from that standpoint in the level or the functionality of the care that you're giving. So it may be, again, very temporary in a mass casualty. So maybe you're getting a ton of trauma victims in and you need to just change your operations for a day or so and then go back. Or it may be longer in a sustained disaster. So that's what it means. So that might mean substituting your supplies, conserving your supplies, adapting your supplies. It might be different ways of operating your staff shifts, or what they do in terms of care for the patient. And then maybe now you're starting to repurpose some space, right? Space that wasn't just a room that could accommodate two, that's only looked after one, then you've added an extra bed in, and now it's up to normal two person per room status, right? Now you're looking at going elsewhere. So let's explore that a little bit more. So in terms of staff, you might be changing your lengths of shift. You might be changing the number of people that you have per shift, and you might be changing supervision, meaning one supervisor who may have maybe supervised 10 or 12 may now have more people under his or her auspices. So some of the changes in actual care or practices that your staff are doing. So maybe you normally do vital signs every 6 to 8 hours, and perhaps you can stretch that out to 10 to 12 hours. So those types of things, or 10 to 12 hours and PRN if you notice anything different in the patient status. From a supply standpoint, you might be adapting those supplies a little bit differently. So you might be using BiPAP or maybe some of the anesthesia machines as ventilators. And we've definitely read and heard of instances where those are pulled from anesthesia and used as a regular ventilator in the absence of or in the shortage of ventilators. Another thing you might be doing is reusing some of your disposable products that could actually be cleaned or disinfected. And so here are some examples here, C-collars, tourniquets, blood pressure cuffs, those kinds of things that might have been at one point disposable, but really could quite conceivably be disinfected safely and accurately using good disinfection practices. So now let's go through how space would be affected in this contingent care era, right? So in the early hours or days of your contingency care, you may think about taking your patients out of pre-induction and recovery areas. Remember, you've probably canceled elective surgeries at this point, and now you're putting patients in those beds that are set up really for pre and post-op. But they're still nonetheless beds with medical gases and still functioning. You just wouldn't normally, under daily operations, use those beds. You might also be thinking about some triage of areas and space. So in order to preserve space for those more moderate and severely acute patients, maybe you're putting aside an area in your hospital for those minor trauma cases. Maybe those are the cases that with a little bit of intervention, some suturing, some whatever, then you can send them home quickly and they're not going to set up a bed. But nonetheless, you've still cared for them. As you progress further in, and now I'm looking at this 2 to 4 hours, you might actually be adding more areas to those pre and post-op areas that you've turned into regular patient care areas. Maybe that's your GI lab. Maybe that's your pulmonary lab. So, and that's important, right? You're using good, viable space that you've used for patients before. It's just used in for different purposes. You may also be transferring patients from a higher acuity area of your hospital to a lower acuity so that you're freeing up ICU beds. We all know that, especially when we're talking about pandemic situations that we are in or have been in, that's where the need is, right? It's often in ICU beds for ventilators. So you want to make sure that you're stepping people down maybe a little bit sooner than you normally would. And then consider patient care in some of your overflow areas, right? All right, as we're moving down 4 to 12 hours or longer, if it's a slow moving disease, now you're beginning to assess whether your facility can actually return to conventional care. Like, are we at a point where we can start demobilizing and transferring down or not? Are we seeing more patients coming in to where we think we're going to be even more overwhelmed? And that's when you need to be thinking about transferring patients out, right? Can you transfer your lower acuity patients to other facilities in your coalition area? And I don't mean just your lower acuity. Maybe it's time to be talking to your partner hospitals about transferring any kind of a patient through. And then finally, at the very end of this time frame, if you know that you're not going to be able to return to conventional status quickly without transferring patients out, then you really want to be thinking about transferring them out now. Otherwise, you're going to have to initiate and get into what we call crisis standards of care. So let's move there. Now, when you're in crisis care, your staff, stuff, and space practices are definitely not consistent with usual standards of care. But what they're doing is they're providing at least sufficiency of care, which is the best possible care given the circumstances, given the available resources for the greatest number of patients, right? It's not optimal. We don't like operating at that level, but it's, again, more of that utilitarian view, right? So there's obviously big adjustments that you're making. So it may mean supply use or supply reallocation, very big changes in staffing roles. You may now be moving from not hospital beds in non-traditional areas that nonetheless have been caring for patients, but now we're into cots in areas that we don't normally care for patients at all. And we have a general scarce allocation or scarcity of resources in general, right? So your staff, you have to be very strategic with when you're in crisis standards of care, right? So you want to make sure that you're taking those specialized staff members and we're using them to provide just-in-time training to maybe your less seasoned staff, maybe your staff that are there whose scope of practice does not include some of the training and the the skills that you need. So, or you're in an area that you're not familiar with, right? So if you pull labor and delivery staff to help you in ICU or some of those areas, you're going to want to give those staff that are not familiar with some of the procedures that you do some just-in-time training so that they can do that and do it effectively and do it safely. And you also want to make sure that you're concentrating your specialty staff in those areas that you're going to really need, right? Like ICU care, et cetera. I have an example here for burn care, and I've had this in my slide for a long time because I can use this. I'm using examples in all kinds of disasters, right? If we have a large burn and blast event, you're going to want those burn nurses and those burn physicians to be gathering their colleagues and partners in those areas and training them really quickly and overseeing the care that those staff that you've just delivered training to are giving, right? So rather than having that burn nurse do the work herself, him or herself in that area, he or she has now got 5 or 6 nurses from other areas that they've trained, and now they're overseeing the work, giving them just-in-time training, mentoring them as they're doing that. So it's just a really efficient way of using your staff so that you can bring in other support staff in areas that may not be as familiar to them. So I think you get the gist of that. Okay, so supplies are also changed, right? You may be reusing supplies that you could use high-level disinfection or maybe even sterilize. So an example would be ventilator circuits, right? Those on a day-to-day basis in normal operations are disposable. So maybe you're using pasteurization to high-level disinfect them and be able to reuse them. So those are the sort of out-of-the-box thinking pieces that I really want people to be cognizant of in this. And this is exactly what you're going to have to do. You will have to think outside the box on how you can be strategic in your reuse of supplies. I'm giving an example from today, right? So we are in the middle of a COVID-19 pandemic, and you know that there are new out-of-the-box thinking when it comes to reusing N95 masks. So we're using UV radiation and other products to sterilize these masks. Well, that's what I'm talking about in this case right here, is really thinking about something novel that can be used in a dire situation, and that's really important. So the second bullet here is talking about reallocations of medications to those who may have the greatest benefit from those particular meds themselves. So here's that same timeline when it comes to space, right? So now in the early phases, you've just flipped from contingent care to crisis care. So now you've used up all those spaces, GI labs, extra bed spaces where you have full medical gases. Now you got patients in the hallways, right? They're not in traditional areas. They might be in your cafeteria. They might be in your gymnasiums. They might be in your activity rooms. It doesn't matter. And there probably won't be medical gases and outlets for them in those areas, but those are just the things you have to do. Now you're really talking about patient transfers, right? You're calling on your colleagues across the state, across the region to help you alleviate your surge. As you move further into that, you might actually be creating areas for austere inpatient care, right? Where you just don't have the supplies to do that. You are in constant contact with your colleagues in your healthcare coalition, and you're talking about transferring patients, or you're talking about getting help from those. And if you have exhausted the areas in your own coalition, maybe you're looking at other regions in the country that may not be as equally affected as you are to be transferring patients. So that's the whole gist here, is that you want to really make sure that this crisis standards of care is implemented for the shortest period of time possible, so that you have time to get patients out, and you can call on your partners in other states, in other regions, to transfer patients to. As you get further into this and you're sort of negotiating that transfer, or you're preparing those patients for transfer, your local health department and your local planners are probably already setting up what we call alternate care sites. And that's right down here under mobilizing resources for alternate care sites. Alternate care sites are those mass care facilities, not unlike shelters, but in an infectious disease event, you want a little bit more separation, where you're caring for patients that have the lowest acuity needs, right? Nutrition, hydration, shelter, those kinds of things. And that's what you're doing in these alternate care sites. And they're often in community centers, in armories, in gymnasiums that are in your community. And a lot of plans are actually already in place for standing up these areas of care. But I want you to know that these are not areas where high acute care are given. Often they eliminate oxygen. They don't take anybody with IVs. So it's really those patients that you would consider in your hospital, someone who needs some care, but definitely not someone who would have a high equipment need, so that we could stand those up quickly. And then in the later phases of your crisis standards of care, as you're moving through, you're really trying to get patients with low acuity out to those alternate care sites, and other patients out to your other partners in the region or the area. So here's just kind of a synopsis of what I've just covered in terms of, space and using like completely non-traditional areas, and it's very disruptive. It's just not what you would normally do. You are taxing your staff to the limit, but you're being very strategic about using more staff, bringing in non-traditional staff. What can you do? Can you be calling on retirees, people that have been retired for the last year, still have maybe active licenses, or a license that can be reactivated because it's been relatively recent. You are maybe calling on staff that have changed professions, but maintained an active or inactive license, and reactivating those. So those are the kind of strategies that you're looking for in staff. And I think we covered the supplies and what you're doing to think outside the box for reusing. This is kind of a diagram that shows the space, staff, and supplies, or stuff, in the left-hand column or the vertical column, and then your 3 levels of care, the horizontal column here, and what the changes are in each of those. And this just condensed all the information that I've talked about into a nice little chart. And what you really want to do, if you think about it, if you can, it's not unusual to be flipping down here from conventional to contingent plans, but you really want, what are your triggers to do that, right? What is it that you are doing in your facility that triggers you to flip from conventional to contingent? So if we look at space and bed spaces, it might be, when you've pulled all your extra beds out of storage and you've put them in regular bed slots, and now you're starting to think about, well, maybe I should be using my GI. If that's your trigger to go to contingent care, then so be it. You make it that. But you want to really define what that is. You also want to try to elongate this contingent care as long as you can. Nobody wants to be flipping into crisis standards of care. So if you can elongate that contingency care by transferring patients out, by bringing in extra staff, by doing whatever you have to do, so be it. But that's your goal here. And then also having those triggers right down here for triggering you to go from contingent care to crisis standards of care. And we described some of those things, right? When you've run out of space, even in your areas where you have medical gases, and you think you're going to have to put people in hallways, then you're really flipping to crisis standards of care. If you are really low on staff and you've exhausted your staff, and now you're having to reallocate, one specialized person overseeing others, then you've really flipped to crisis standards of care. If you're talking about scarce allocation or reallocation of scarce resources, like ventilators, then you really are in crisis standards of care. But you need to list those triggers and what would push you from one area to the other. When you get into crisis standards of care, you really want these clinical care teams that are making some very difficult decisions. You do not want the bedside clinician making decisions on reallocating a resource from one patient to another. It's just not a good idea. And there's certainly guidelines for who should be on these clinical care teams, to include ethicists, physicians, nurses, behavioral health therapists and specialists. So those are the kinds of things that you need to have, and you want to have those ahead of time. And then you want to develop policies for what that means, right? At what point will you not intubate when you don't have ventilators? Can you intubate in bag without a ventilator? These are highly ethically charged decisions, but you have to make those preferably at more of a regional level, so that you don't have different facilities with different policies, but it's nonetheless a policy that you want to make sure that you address, because those are not conversations that you want to have in the middle of a disaster. That's the worst time. These are some of what I wanted to do is I wanted to share some of the examples that are out there for allocation of scarce resources. And this is one from this comes from, yeah, the crisis standards of care that the Institute of Medicine established in about, they started their work in about 2009. They released the actual document. They're now known as the National Academies of Science, but back then it was the Institute of Medicine. And these are some of the point systems that they allocated to patients. If you had to take a resource that's scarce from one patient and allocate it to another, or if you had 10 patients and you had 5 of such a resource and you had to allocate that, these are the guidelines that they've been using to do that. So it's very difficult decision, but at least it gives you something to quantify or score a patient in that sense. And these are the ones, a little bit different, that I took from the Utah Crisis Standards of Care guidelines. So it's a little different one. The point is here is that there are a couple of tools out there. Some of them have different nuances than others, but at least it's something that a region or an area can use and use consistently across the area for the allocation of those scarce resources. And I just wanted to give you some examples. Triage is something that I said here is a whole other lecture, which it is, but sometimes you're going to be reallocating resources based on secondary and tertiary triage, right? So you might have someone who comes in for whom their prognosis is great, but have somewhat deteriorated, and maybe they'll fall under different scoring systems. So I just wanted to bring that to your attention here as just an FYI kind of thing. So I wanted to go over some of the things that in the planning for crisis standards of care needs to be taken into consideration when you're planning for these type of operations. You can only imagine how disruptive it is, but you've got to have ancillary systems in place to make sure that this works really well. So getting alerts in and out are going to be really important, right? If you're in crisis standards of care, you need to be able to be in constant contact with your emergency management system, your law enforcement, your public health departments, and your weather service if you're talking about severe weather events. You have to have triggers for standing up your incident command and for activating your crisis standards of care. And that's really important. And we talked a little bit about that earlier. You have to be able to notify people, right? Internally, you need to be able to get a hold of your healthcare staff, your specialty care staff, your administrative and support staff, because as you're ramping up, you're using everybody to the greatest extent that you can, and in ways that they may not be typically used to working. But you've also got to have notification to your external, right? You need to be able to talk to your EMS and your coalition partners and any technical experts that you might need that help you, and that you need to be training your staff on what's understood and what's in their policies for what they can expect in contingent and crisis standards of care. You have to make sure that you have a well-oiled machine when it comes to hospital incident command, right? You'd have to do a ton of training with the folks that are going to be in your emergency operations center, playing those roles, right? Your command staff roles, your section chief roles in an emergency operation using the incident command system. And many of you that are listening to this have been trained in that system and understand that, but that doesn't come second nature to most people. So it's really got to be something that you've spent time training your folks that are going to be operating your incident command. So more about communication, situational awareness is important, redundant methods. So if you're normally used to using pagers or phones and your phone lines go down, you need to be thinking about what's your next line of communication. What is your redundant method of communication, both externally to your facility as well as internally? You know, sometimes internally that means runners, right? Something as easy as designating people that run around the facility in the absence of being able to communicate electronically. So that's really important. Your facility needs to be able to practice performing conventional care, contingent care, crisis care. What does that mean, practice? It means you have a policy, you have a procedure, and you exercise that procedure using drills and tabletop exercises and functional exercises and full-scale exercises so that these things become second nature with your staff. They will revert to whatever they've practiced. So the more you practice this, the better that you're going to be. And you want to make sure that you're including all of these things in your plans, your mental health, your palliative care, how you're going to do that. Remember, we talked about austere care in some of those crisis standards of care areas. And that triage team that you've allocated to make some of these difficult decisions. They should be assembled well ahead of time, and those conversations should happen well ahead of time. And lastly, you want to make sure that you've got a strong logistics component that goes with your crisis standards of care, right? These are the people that are going to be planning out and getting you the supplies and the things that you need to establish your care in non-traditional areas, right? They need to know where your redundant supplies are. They need to know what your substitutions, where your substitution supplies are, and they should be equal partners in this allocation of scarce resources. And they're the ones that are going to try to get extra supplies from either local, regional, or federal assets. And everything that you get in terms of supplies for your facility will go through your logistics folks. And they play just a really important role in that whole process. So from staff to supplies to everything else. So thank you. That's a whirlwind tour through crisis standards of care. Hopefully you are leaving this presentation with a general sense for what those 3 levels are, a general sense for what the triggers are from going from one to the other, and the challenges inherent to each one of those levels, particularly contingency care and crisis standards of care. And hopefully I've also imparted the notion that this is something that needs to be planned for long ahead of the disaster. I've given you an overview of what it might look like in a quick moving disaster, as well as in a slow moving infectious disease disaster. And I think you can sort of see how it would happen in either way, and how the reliance on outside and partnerships is going to be very, very important to go through this. So hopefully that's helped you, and that you have a better sense for the whole the concept in general. So thank you so much.